Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. Today, we're talking about charge capture, what it is, why it matters, and where health systems lose revenue every day. Charge capture is simple in theory. It is making sure every medication and service that should be billed actually gets billed. But in practice, it is one of the easiest steps to miss. Charge capture is not one action. It is an operational discipline that sits between clinical workflows, documentation, system build, and billing logic. If any one of those breaks, revenue is not just delayed or denied, it is completely lost. Charge capture is the bridge between care delivery and reimbursement. If that bridge fails, nothing downstream matters. You cannot bill what you did not capture. There are 3 ways charges are generated: charge on administration, or COA, charge on dispense, or COD, or manual charging. Most organizations operate in a hybrid model heavily skewed towards charge on administration. Charge on administration means the charge is triggered or dropped when the medication is documented as given on the medication administration record, or the MAR. No administration, no charge. Charge on dispense means that the charge is triggered or dropped when the medication leaves the pharmacy. At a high level, COA aligns revenue with patient care. COD aligns revenue with operational activity. The advantage of charge on administration is accuracy. You are charging based on what is actually given. That improves compliance and aligns with payer expectations. The risk is documentation. If it is not documented, it is not charged. Areas of low documentation rates or barcode scanning rates translate directly to missed revenue. Charge on administration creates the potential for undercharging. The advantage of charge on dispense is that there are no missed charges. It does not depend on documentation. However, the risk is accuracy. You can charge for medications that were not given. This creates compliance exposure. You also have to return the doses, which adds an administrative burden and creates rework. COA is the industry standard, but it only works if documentation is reliable. Health systems need to understand their barcode scanning rates, documentation rates, and workflow gaps. Some areas may still require charge on dispense. An example is for medications documented in different modules or different areas of the EHR, such as contrast, depending on how that record is built. The goal is to find the right model for each workflow. Another area I want to focus on is areas that have one-step medication activities, where providers can enter the order and document that the order was given all in one step. Examples of this are code narrators or in the OR or procedure center. That one action triggers the charge. However, there is no backup. Missed documentation means missed revenue. The risk is the workflow. These areas need strong governance and monitoring, where you compare what was dispensed to these areas and whether those charges were captured. Clinics do not administer medications as frequently as inpatient or procedural areas. Because of the frequency of medication administration, Workflows are often less standardized. It is common for a medication to be given and documented in a progress note, where the assumption is that the documentation alone is enough. It is not. If that documentation is not captured in the structured workflow tied to the charge does not drop. Clinics are a major source of silent leakage. Every organization should have a charge map. Where is charge on administration? Where is charge on dispense? And where do manual charges continue to exist? Are there workflows that break the process? Those workflows tend to be where revenue is lost. When thinking about charge capture risk, think about therapies like Suprelin, which could be given in the procedure center or in clinic. Botox, often given in clinic. Zugamadex, given in the operating room. Xolair, steroid injections, as well as Cabenuva or Apretude, given in clinic. Different drugs, different settings, different workflows, but the risk is the same. If the charge trigger does not align with how these drugs are documented and administered, you miss the revenue. You might be asking yourself, are all mischarges the same? A nurse misses documentation of a $25 antibiotic. The charge is missed, not ideal, but manageable. From a compliance risk, you need to have these documented somewhere in the health record, but from a financial risk, this is not a big exposure. Now let's make it a $1,000 outpatient infusion like infliximab. Now it matters. Now make it a Spinraza given in the procedure center. Now you're talking about significant revenue. Let's take it a step further. It's a cell or gene therapy dose. That charge is not just a mischarge. It is a financial event that will impact the bottom line. So what drives charge capture? 4 things: system build, workflow, charge triggers, and reconciliation. Reconciliation is where most organizations fall short. You should be comparing what was purchased, dispensed, administered, and billed. If those numbers do not match, you have leakage. That leakage could be diversion, or it could be inappropriate charging. Depending on where those numbers drop off, you can find your workflow gaps. An important part of the process when assessing what was purchased, dispensed, administered, and billed is to assess the area that these medications are going. You may have the same drug, let's take Botox for example, where one clinic has excellent documentation rates and another clinic doesn't have great charge capture. By separating the data into dispensed location, you can then target education and work on improving documentation rates. Another area that you want to look at is if each area is correctly capturing waste. If you're not capturing waste for eligible discarded drugs, you are losing reimbursement. And if you're a 340B covered entity, you are also missing out on accumulations. You must reconcile these numbers. Assuming the system is working without validating it will not work. Charge capture sits between teams, which means it truly sits with no one. Charge capture is not just about billing. It is about making sure the care delivered is recognized in your financial system. It is about protecting margin and ultimately sustaining access to care. Healing patients is the mission. Protecting the margin is the strategy. This is Revenue RX. As always, the content shared in this podcast are for informational and educational purposes only. The views shared are my own and do not represent any organization I am affiliated with. This is not legal or financial advice. Please consult your internal experts before making any decisions.